Welcome back. For those that are new to the channel, my name is Dr. Taylor. I'm a board-certified emergency medicine physician. I'm also on staff at multiple hospitals, ranging from small community hospitals to large academic trauma centers. In addition, I serve as a flight surgeon in the United States Air Force. You'll notice the start of this video is a little bit different, and that's because I've been away at Air Force training. So I just finished a long day. I get back to my hotel room and I thought, what better way to end my day than by doing the episode 5 critique? So without further ado, we're going to be doing episode 5 of the PITT. Again, a detailed analysis. We're going through everything. So let's go.
Neuro exam, dude just dropped, no warning.
What's open? Trauma 1.
So if you recall from episode 4, this is the patient that was in the waiting room waiting to be called up when he had a seizure. The staff appropriately responded and brought him back.
What do we got?
Seizure and chairs.
Thank you. How is it out there?
Chaos. We're never gonna catch up.
We're never going to catch up. Now, sometimes it does seem that way. Patients keep coming, that bolus keeps happening. Patients are lining out the door. Although sometimes on holidays it stops. Before Sunday lunch it stops. Now after Sunday lunch it's going to pick up. It's funny how an emergency visit can change based on the weather, based on the time of day, if there's school the next day, if there's work the next day. It makes you wonder sometimes, if those factors truly change your visit to the ER, is it an emergency?
Another 4. Yeah, no history. Doesn't look like he's been here before.
Starting low 90s on 5 liters.
Here he mentions Ativan. Ativan is a benzodiazepine. It's used for a multitude of things, including seizures. Now, the typical dose for Ativan for adults is going to be 2 to 4 milligrams. Now, it's going to be important for this case, and I'm going to put these numbers on the screen for you. The onset of action of Ativan is typically within 5 to 10 minutes. Within 5 to 10 minutes, we're going to start seeing an effect of the Ativan. It's going to peak at its highest point around 30 minutes. And it can last for 2 to 6 hours, so it's a little bit longer acting. So again, onset within 5 to 10 minutes, it's going to peak at about 30 minutes, and it's going to last for 2 to 6. This is in contrast to another benzodiazepine that we often use for seizures, amongst a multitude of other reasons, and that's Versed. So we're typically going to give anywhere between 2 to 5 milligrams as a pretty standard dose. The onset is literally 1 to 3 minutes. And I've had plenty of these that literally within 45 seconds, we're seeing an effect. 1 minute, 2 minute, we're seeing an effect. It's going to peak at 5 minutes, and the duration is a little bit shorter. It's going to be 30 to 80 minutes. So just from that timing, you may say to yourself, if our goal is to stop a seizure right now, limit any further brain damage from the continued seizure, wouldn't you rather give something that works a little bit faster, like Versed? We'll talk about that a little bit later.
Another 4 milligrams?
Can't get the top off.
It's just the plastic, not the...
No, I know.
Here, give it to me.
No, I got it.
Okay. Ordering CBC, CMP, and a straight cath for a urine tox.
So where are my nurses here? I think later we see them show up, but seriously, nurses are typically going to administer this medication during a seizure. I don't see any nurses at all in this scene, and overall it's not realistic based on that. If you recall back to episode 1, Dr. Robbie was giving calcium, and that's something a nurse typically gives. We see this all the time in TV medical dramas. Attendings and residents are pushing medications that the nurse would normally push. So again, I ask, where are the nurses here? Where are my rock stars?
Pushing the second floor? If this doesn't work, we need to prep Kebra.
No, we'll give more Lorazepam. It's already ordered.
So this next part of the critique, we're going to really look at kind of the timeline of medications, and we're going to compare it to a few other things. Because again, you can manage seizures a few different ways, but at the same time, we want to limit how long that patient is seizing for. The longer that they're seizing, the worse the potential outcome. So in this case, the patient had 4 milligrams of Ativan previously for the seizure. Now they're getting another 4 milligrams of Ativan. So we're up to 8. She states, if any more, she mentions to prep Keppra, and he states more Ativan. My critique with this is that, remember, Ativan takes a longer onset of action. It's 5 to 10 minutes. Ativan is great, but Versed would be better here. Again, 1 to 3 minutes. In reality, what we're doing is the patient is getting Ativan and likely Versed sometimes at the same time, while we're also loading Keppra. So that Versed is starting to have an effect as it's wearing off. Ativan is also starting to have that effect, and we're loading with Keppra at that same time. Typically a 1 to 2 gram load. Again, it's weight-based, so some it could be even more than that. All of this is being done at the same time. Again, I'll put this on the screen. Ativan for an adult, 2 to 4 milligrams is pretty standard. onset of action, 5 to 10 minutes, peak at 30 minutes, last for 2 to 6 hours. In comparison with Versed, 2 to 5 milligrams, again, standard for an adult. Kids, it's much different. Onset around 1 to 3 minutes, peaks at 5, lasts 30 to 80 minutes. Now, first-line treatment is a benzodiazepine. In this medical drama, they're giving a benzo, right? They're giving Ativan. We've already talked about Versed. Valium can be another one. Again, benzo, benzo, benzo. Second-line medications include like Keppra, fosphenytoin, Depakote. Third line for refractory seizures, propofol is being given. Different story, and so that's not the goal of this part of the critique, is to talk about the exact management of seizures and what happens if it continues seizing, what we do with the ventilator. That's not the goal of this. And later we're going to learn that the patient's only been seizing for 4 minutes. Now you may remember, wait, if the patient's been seizing for 4 minutes, we've given 4 of Ativan, we're waiting a minute or two, hitting with another 4, we haven't even hit our onset of action yet. So that's my only critique with this scene.
He's already had 8 milligrams. He'll stop breathing.
Then we'll intubate. Sometimes the patient needs a little more. How long has he been seizing?
About 4 minutes ago, he started seizing in chairs. He's already had 8 of Lorazepam. I want to move on to Keppra, but Dr. Langdon disagrees.
Just want to try another 2 milligrams before moving on.
Dr. Langdon's patient, Dr. Langdon's call.
So my critique with this is that when we get a seizing patient that is brought back into a patient's room, yes, we're getting meds ready, yes, we're setting up suction, but there's a few things that we're doing even before that, because again, we want to limit aspiration. All the stomach contents, all of the gastric acids, anything that's in the stomach from going into the lungs. And to do that, we lay them on their side, all right? We want to limit that as much as we can. In this case, you watch, the patient's laying flat, they're just foaming at the mouth, they're just aspirating. Please, somebody turn this patient, hook up suction, try to prevent that aspiration. Where is respiratory? We rarely see respiratory in this TV series. So all of this is being done while we're giving the patient a benzodiazepine like Ativan or Versed. Now, sure, as a resident or an attending, I've set up suction numerous times while we're waiting for respiratory or waiting to intubate. The nurses set up suction as well. But in TV medical dramas like this, we rarely see respiratory.
Another 2 of Lorazepam.
For a total of 10.
I'm well aware.
He's still seizing.
So here they're giving another 2 milligrams of Ativan. I believe at this point we're up to 10 milligrams of Ativan, which in some patients, this seems like a lot of Ativan, but in others, not so much. It really depends on the clinical situation. I will say, patients suffering a Benadryl overdose, for example, that have a significant anticholinergic toxidrome can often require numerous rounds of Ativan and Versed before ultimately a possible intubation. Patients that overdosed on PCP, for example, can handle quite a bit of Ativan as well. So you really cannot rely simply stating the milligram of Ativan the patient receives. Oh man, that patient got 10, we should intubate. Again, it depends on the clinical situation. The ultimate goal is to stop the seizure at this point.
Call respiratory. I'm setting up an intubation chair.
Which he won't need.
Dr. Santos, what is the definition of status epilepticus?
Seizure lasting more than 5 minutes or at least 2 seizures without full recovery in between.
Excellent.
So this is just a spot-on definition of status epilepticus. I don't have a critique on this, but obviously, throughout this series, there's going to be plenty of teaching points. At this point, the reason for the seizure potentially lasting so long is honestly partly due to a timing issue of the medication. At this point, the patient's been given multiple rounds of Ativan. We know the exact timeline so far, and this patient has been seizing for 4 minutes. 4 minutes. Now, we need to stop that seizure, but let's recap that onset of action of those meds again. Ativan takes 5 to 10 minutes on average to start having an effect. This is something that I see often in the ER, more so in residency than anything, that you keep pushing Ativan when your peak effect still has not hit yet. In reality, this patient needed 2 to 4 milligrams of Ativan, yes, potentially even 5 milligrams of Versed as well, or even before, and then also loaded with 2 grams of Keppra. These will all start working at the same time. So they give 4 milligrams, time to onset starts, then they give another 4 milligrams before that onset. And then what happens is, then they're giving the 2 milligrams. So again, this patient's only been seizing for 4 minutes. And you can see the issue with this. This is a senior resident and he should know better. Now the intern does question all this as it seems like a lot and it's not working. Again, she also doesn't know the timeline as well. Otherwise, she could have said something to the senior like, hey, we keep pushing Ativan. Do you think maybe we should push Versed because we keep giving this medication and it's only been 4 minutes? So again, there's times where the senior resident looks awesome, right? He seems like an awesome senior resident. He seems great. And then other times, he's hopping up and down during a debrief after a cardiac arrest. He's poking on a flail chest. So again, there's times where he seems awesome, and there's other times I start questioning some of the decisions he makes. But if this seizure would have stopped with Ativan and Versed given immediately, we wouldn't have a good dramatic scene for television. I see this patient, they're coming into the ER, respiratory is there, nursing staff is there, they're being turned on their side, we're suctioning the secretions, we have IV access, the patient's getting a dose of Versed and they're getting a dose of Ativan, ER pharmacy is drawing up Keppra, the seizure is going to stop before 4 minutes. And then at the same time, now we're entering that post-ictal state, we're monitoring that patient. All of this is done relatively pretty quickly, but if we do it how it should be done in emergency medicine, we wouldn't have a good dramatic scene like this. It wouldn't be drawn out. And so I guess, for the sake of this, let's just keep pushing Ativan, right, for good medical drama. Let's not push at anything else. And what I also have to say with this is think of it this way. And sometimes in residency, we use ketamine intramuscular. So it's used for a lot of different things, including, pain control, sedation, that kind of thing. And you can give ketamine intravenously, but you can also give it intramuscularly. So the dose for kids with this is 4 milligrams per kilogram given intramuscularly. That peak effect is 5 minutes. This is much different than if we're given ketamine intravenously, which typically peak effect is in 1 to 2 minutes. Now you can see the potential safety issue with this. Let's say you push this dose in kids, you don't wait for that onset of action intramuscular. You don't wait long enough to consider second dosing. And you're like, man, the IV form took 1 to 2 minutes. I don't understand why the IM form is taking so long. So you push the next dose again, potentially push the next dose again. What happens is you're giving that child too much ketamine, and at that point, you're risking all the side effects of that medication and potentially the consequence of what happens if you over-sedate a child. And so, again, that's my overall critique with this scene. But again, it makes it great for television. It makes it very dramatic for television. If we just kept pushing the same medication, not waiting for that onset of action, and it makes for great TV.
Seizure activity has stopped. Also excellent. Spontaneous breathing. Good tidal volume.
Sats up to 98.
Welcome back, Mr. Marino. Nice work, Dr. Langdon. I will be at Central if you need me.
This must have been a bad vial. 8 milligrams should have worked.
According to your textbook of emergency medicine, but sometimes they need a little bit more. You'll learn that with time.
But why couldn't I open the vial?
Because you're an intern. Who also needs to learn to trust your senior resident, especially in front of an attending. Now, check his labs, babysit him until he goes to CT, and get some blankets on these side rails as a seizure precaution.
Because you're an intern, or maybe because you're not the nurse, as they would normally open this medication and give this medication. Just saying. Also, again, that time of onset of action, you're pushing 3 rounds of Ativan within 4 minutes and wondering why you keep pushing it. The only thing I can think of is that if it's been tampered with or there's a potential medication issue as well. So in addition to these critiques, I also do YouTube shorts as well. So we're going to take a brief 1-minute break and go through one of the shorts that's available on the channel. Welcome to the ER. My name is Dr. Taylor. How can I help you today?
Yeah. Hang on, doc. Just one sec. Sorry about that. What'd you say?
How can I help you today?
I've had this chest pain, and it's like right here, and it'll like move into my jaw and down my arm. And I just figured it's because I'm not exercising.
I see. So what makes it better? What makes it worse?
Well, initially when I walk, the chest pain would get worse, and then when I rest, it'd get better.
I imagine that the nitro that EMS gave you helped out.
Oh, you mean those vitamins underneath my tongue? Yeah, after the first one, it was good. Third one, I feel great. If I can just get a bunch of those, I'll be good.
Okay. What medical history do you have?
I don't think anything really.
Doc, so he definitely has high blood pressure. He doesn't take his meds sometimes, and that his sugar often is pretty high as well. He's got at least 1 stent in his heart. I think he's got a couple, and some of those stents have stents. He's been needing dialysis pretty consistently.
That's a good amount of medical history. What medications are you on? I think I just take a few vitamins, but really it's not even that many.
Doc, here's his book. We're actually from out of state, and I just want to keep everything organized for you.
Okay, thank you. All right, let's take a look at this. All right, I'm seeing 43 medications.
Sir, are you taking all these medications?
Yeah.
Sir, I'd like you to please put down your phone. Physical exam may be unremarkable right now, but I'm highly concerned that this is your heart. Okay, can I get a cup of coffee and one of those nicotine patches? Let's get back to the critique.
Gonna hurt?
No. Skin's dead. You won't feel a thing. First time in Moab?
No. I belong to a club. Gears and Beers. We started riding the Frick Park during the pandemic. Just something to do to get out of the house. But we all stuck with it, and Now we go on biking trips. Oh, whoa, oh, oh, do something, man. Oh, dude, whoa.
I need a little help here! Jesus!
Hey, what's up?
Arterial pumper under a blood blister. Let's see.
Oh,
Jesus!
God.
No. Hi, I'm Dr. King, and we can fix this.
Did you cut an artery?
No. I punctured the top of the blood blister, but there is an artery hiding under there.
Hiding? Like you didn't know it was there?
I love this. Sometimes in the ER, you have bleeders, as we call them. Here he cut into a hematoma, and there's reportedly an artery behind it. Now, you can see this vessel just pumping out. That's how we know it's an artery. If this was a vein, it would just, it would just gush out. And so there's a lot of body fluids in the ER. Rather you're draining an abscess, this abscess could be anywhere from head to neck to face, the upper buttock, a Bartholin gland abscess, literally an abscess anywhere. And these can range, hematomas even, literally anywhere. And so it's also important that you have a mask on when you're doing this. You don't want to get sprayed in the face. Sometimes if you're potentially going to go into a hematoma, you want to be gowned up so you're not having to go through 3, 4, or 5 different rounds of scrubs on a shift. And another one is a bleeding dialysis fistula. These can be very life-threatening, and I've seen some bad fistula bleeds where you have a patient on anticoagulation even, and they come into the ER and this fistula is bleeding. They were just at dialysis, they had an access, they come into the ER, there's already like a tourniquet on, but it's not doing anything, it's just bleeding out. And so at this time, we're fixing this with a figure 8 suture, and typically 1 or 2 sutures. But the amount of bleeding that potentially can go on, the amount that we're gowning up, again, we have something covering the face, the head, we have something covering really neck all the way down. And so we want to prevent having to change our scrubs numerous times. But we also want to protect ourselves as well. Again, you don't want to get blood in your eyes or anywhere else. So this medical student keeps having stuff like this happen to him, which is very realistic. Now, I can't say in my training I've had to change my scrubs this many times. I think I've changed it twice at most on my shift. And but it does happen.
Don't you have to know basic anatomy to become a doctor?
He's a student doctor.
What the fuck? Student? Oh, hell no. Can you help me? Can you fix it?
A little forward. There we go. All right, you can let go. Yeah? Mm-hmm.
Thank God. Thank God.
All right, Whitaker, 10 cc's of 1% lidocaine with epi.
Yeah.
The shot is going to numb the area and also constrict any blood vessels so that we can put a little stitch in there.
What happened in here?
Hidden laceration of a arterial under the vesicle. Bleeding stopped at 180 on the BP cuff, and we are now injecting lidocaine with epi.
Thank you, Dr. King. Let's set up a suture tray with 3/0 nylon. Okay. Now you can place a figure 8 suture.
I've never done one of those before.
The patient's facial expression here is just so accurate. When I was a medical student, I remember multiple times when you're about to do a procedure and the patient finds out you're just a medical student, as they call them. Oh, he's just a medical student. We want somebody else. And sometimes they have so much hesitation. They start to freak out. The resident has to come in and reassure them, or even, the resident's bedside for the procedure. Let's say the procedure goes awesome. Then you both end up chatting it up and you really kind of share everything. And then, now he likes medical students. So for those watching, you may have had a medical student do one of your procedures and you actually had no idea it was a medical student because they were so good. Now there's always the opposite as well. You had such a horrible experience and then you found out it was a medical student. So again, it happens.
Look, maybe you should just do it.
You should definitely do it.
Whitaker's got this. It's easy. Just 2 stitches in 1. Take a big bite, a simple interrupted suture anterior to the bleeder.
Okay.
Now instead of tying, through another one posterior. Looks good. Now a normal tie for a figure 8.
What did I miss in here?
I am so sorry. I just...
Made an excellent catch and saved Mr. Chasen's life.
Really?
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 There was a cut arterial under a blottable vesicle. If Mr. Chasen had gone home without debridement, the blister could have eroded with uncontrollable hemorrhage.
Nice work. Jackson Polycare might want to go hit the Scrubs Exchange.
Yeah.
The patient we keep seeing in the waiting room for quite some time now, literally in every episode. So again, I really hope that this is a good case. Now, this is the episode 5 critique. I've already watched 6 and 7. I have not went on any further than that. I try not to go at least more than a couple ahead. Really depends on the case that I'm covering. So again, I have not reached all the way up to 9 and 10. I'm trying to stay off of seeing any reviews for this because I know there's a lot out there talking about it, but I've only watched up through the next few. So I really hope that this is going to be a good case.
Earl, what are you doing out here?
I'm hungry.
Get back inside and we'll get you a sandwich.
No egg salad.
Sure.
Excuse me. I've been here for over 5 hours, okay? Way longer than that chick. Can you check the list? Driscoll, Doug, Driscoll.
So he states that he's been here longer than the other patient, right? For any future ER patient watching, it's more than the length of stay, and we've discussed this on previous critiques. When you're triaged, it's the initial clinical presentation, the history, the vitals, etc. That guy does not know what happened to her, right? He doesn't know her vitals. He literally knows nothing. He's making his decision purely based on how long he's been waiting and how long she's been waiting. This happens all the time in the ER. Patients get mad that someone else that was waiting less than them gets called back to a room first. But they need to realize there's a reason the other person is coming back. To be honest, all right, I am completely honest right here. For anybody watching this, if the ER is not empty, it's full. There's 50 people. It's lined up out the door, right? It's a massive, massive ER, and it is lined up out the door. It is so busy. I want you to think beyond busy, all right? Maybe even 100 people in that waiting room. Something's happened, massive influx. And you're the one that comes into the ER. You go to that front desk, tell them what's going on, and they bring you back immediately. You are the one that should be worried at that point. Emergencies don't wait.
Everybody is seen as quickly as possible and in order of medical care needed.
Unless they die waiting.
Would you get that, Mr. Driscoll? It's actually time to bring you back.
Thank God.
Would you take care of Mr. Driscoll? Yeah, absolutely. Sherry, you're with me? Oh, yeah. Yeah, let's take care of this.
Hey, I need a minute.
I already put $20 on disgruntled ex-EMT caught outside of our catchment.
And I will gladly take your money when that mess is over, but this is about a patient. Christy Wheeler, 17 years old, pregnant. These are Abbott's fetal measurements from yesterday, and these are mine.
10.5 and 11.2. Well, ultrasound is an art, not a science. Even in the very best hands, the EGA differential can be within 3 to 5 days in the first trimester. Definitely room for error.
If you recall from the 4th critique, this was a 17-year-old that presented for a medication-induced abortion. The night shift doctor did an ultrasound for estimated gestational age, EGA. They came back, and now a different physician was seeing them and basically had to repeat everything.
Not if you're here for medication abortion and you're past the mandated 11-week cutoff.
Now, they mentioned a mandated 11-week cutoff. Now, I had to look this up myself as this episode deals with ER physicians administering this medication, and I'm just not familiar with this. So I texted a few ER doctors from various hospitals across the country. These are, physicians that I know. These are physicians that I trained with. Some graduated before me, some graduated after, and I struck out. I am 0 for 30 of this medication being given by an ER doctor that I know of. And that was ER docs from various places across the country. So some of this obviously is provider dependent. Some of this is state dependent. In this case, it's Pennsylvania. And, it's also hospital dependent as well. It's clinic, it's versus hospital versus obstetric. So there's a lot more that goes into this. So to provide you with the most accurate information, this comes from Mount Sinai, and this is off their website. They state, in quotes, medicines can be used to end an early pregnancy. In many cases, the first day of your last period must be less than 11 weeks. If you are over 11 weeks pregnant, you may need to have an in-clinic abortion. Some clinics will go beyond 11 weeks for a medication abortion. Further, when getting ready for an abortion, the provider will do a physical exam and ultrasound. We'll go over your medical history, do blood and urine tests, and explain how the abortion medications work and have you sign consent forms.
There can also be interoperator variability.
I measured the gestational sac, 11.3, and fibroidal diameter, 11.1. I didn't get a single measurement under 11 weeks.
So what are you saying, that Abbott lowballed his measurements to help a teen get the abortion that she wants?
Maybe.
So the senior resident here is saying the night shift doc had measurements under 11 weeks. And if I recall, there was no mention of how many readings under 11 weeks he had, only that it was under 11. Also, the fact that she knew about his ultrasound for estimated gestational age tells me the night shift doc must have did a medical chart, put something in the chart somewhere stating it was less than 11 weeks. And then again, how many readings did he get? But, it appears that he didn't do an actual ultrasound and put that in the chart, only that the reading is under 11. So with these point of care ultrasounds that we do bedside, we have the ability to upload them into the patient's chart. We give our interpretation, we put them in the medical chart. This is in comparison to a formal ultrasound that we order. It's done by an ultrasound technologist, and then it's read by a radiologist, and it's uploaded in that patient's chart. So now she has 2 readings that she did over 11 weeks. So according to the American College of Obstetricians and Gynecologists, the American Institute of Ultrasound and Medicine, and the Society for Maternal Fetal Medicine, they make the following recommendations regarding the method for estimating gestational age and due date. Ultrasound measurement of the embryo or fetus in the first trimester, up to and including 13 and 6 and 7 weeks gestation, is the most accurate method to establish or confirm gestational age. Up to and including 13 and 6 and 7 weeks of gestation, gestational age assessment based on the measurement of the crown rump length has an accuracy of plus or minus 3 to 5 days to plus or minus 5 to 7 days. Measurement used for dating should be the mean of 3 discrete crown rump length measurements.
Well, then you've got 2 choices. You can go with Abbott's measurements, or you can redo your measurements, go back in and pick an angle that shows 11 weeks or less.
Please tell me you're joking.
You were ready to roll up your sleeves and arm wrestle the ethics committee a couple hours ago to override Mr. Spencer's children. What changed?
Apples and oranges. There was a clear, bright line that Mr. Spencer was never going to make it. Falsifying medical records for Christy is flat out illegal.
She's 17. She deserves a life.
Of course she does. But I will not jeopardize my future in the process.
You'll be fine.
Someone finds out I falsified medical records, I'll get booted from the residency program. You've got tenure. Worst case, you have to take a job in Youngstown. The risks are not the same for you as they are for me.
I think overall as an ER doctor, I was the most disappointed for this scene. So far I've critiqued now, this is my 5th critique. And up to this point, I'm just so disappointed with how the scene plays out. And again, I would say it's not realistic, but at the same time, I'm sure this happens. But overall, I think this scene was very unprofessional and unethical in terms of what he's asking her to do. Again, I'm not talking about abortion versus no abortion. That's not what this critique is. I'm purely talking about what he is asking her to do here. He's asking her, repeat the measurements and ensure they're under 11 weeks. Basically, continue to ultrasound that patient until your measurements are under 11 weeks. Even if she was to get 8 measurements over 11 weeks, he wants her to get a measurement under 11 weeks to help this 17-year-old out. Now, at first, the resident thought the attending is just joking. Why would he be serious about this? This is ridiculous. I'm not gonna, kind of fudge a measurement just to help this patient out when in reality, I keep getting measurements over 11 weeks. So this is disappointing and I did not expect this. Now, the next question is, how does this, how do you go about this situation in reality? What happens if you're a resident and your attending says, I need you to help this 17-year-old out. I understand you keep getting readings over 11 weeks, but I need you to make sure in your chart that's under 11 weeks. Now, this is a larger hospital with a trauma center in Pennsylvania that has access to a multitude of imaging modalities, including formal ultrasound. Now, if you recall from episode 4, the ACGME, so the American College of Graduate Medical Education, mandates procedural competency for all EM residents in emergency ultrasound because they consider it, in quotes, a skill integral to the practice of emergency medicine. So for general emergency medicine residency, again, we've mentioned this in the last critique, a minimum of 150 total emergency ultrasound exams are required. Now, over my 4 years of residency, I passed this number by a lot. But again, realize this is not a fellowship in ultrasound. This is just part of the curriculum. And so these ultrasounds are going to range anywhere between, a cardiac ultrasound, you're doing a kidney ultrasound, you're doing, skin ultrasound, you're looking for cellulitis, you're going to be ultrasound for intrauterine pregnancy. There's a lot of different ultrasounds you're doing. But there comes a point when, given the situation, you should just get a formal ultrasound. This is one of those situations. Just get a formal ultrasound. In this case, you can just do a transabdominal ultrasound. The probe is on the outside, and just get it. The radiologist is then going to read that ultrasound, and an official impression is placed in that patient's chart. For example, the radiologist is going to read that exam as the baby or fetus is 10 weeks and 3 days, plus or minus 5 days, for example. Again, they're taking into consideration that discrepancy. So when we see 10 weeks and 3 days plus or minus 5, we're going with 10 weeks and 3 days. So for this, again, I consulted a few of my OB colleagues because I want to bring you the most accurate information in this case. And if radiology is reading, for example, 10 weeks and 3 days plus or minus 5 days, we're going with 10 weeks and 3 days. If it's 11 weeks, in 2 days plus or minus 5 days, we're going with over 11 weeks. So again, just get a formal ultrasound. My guess why they didn't here is that this hospital portrayed does not have an ultrasound technologist, which again, I highly doubt based on the size of the hospital, being the location of where it's at, the fact that it's a trauma center. So what all that means is producers, editors, consulting physicians choose not to get a formal ultrasound here because it looks better to get everything done bedside for TV. Again, you have 3 different doctors, 2 attendings, 1 resident, each with different readings. Again, this is putting you in a very sticky situation. You're almost kind of crossing boundaries.
You're right. I'll do it.
What?
Erase your history, physical, and impression from Christy's chart and be like you never saw the patient. I will take over. I will complete a new chart and upload my own image.
Robbie, I'm not asking you.
So here he's asking her to delete her chart and unassign herself from the patient as it would be like she never saw the patient. Are you kidding me? Is this a joke? You cannot just delete the chart. I suppose it does depend if she shared the note, if she signed the note, or even if she started her note to begin with. But so many factors here. You can't just delete yourself from all of this. You are attached to that patient. You're attached to that. So you've already assigned yourself as the provider. You've already saw the patient. You started a note, potentially uploaded an image already, in the ultrasound machine up into the patient's chart. Depending on the ultrasound machine itself and the capabilities, it's probably already there with the measurements. So you cannot just delete these. Overall, very disappointing scene for sure. And I'm still shaking my head as I did not realize I would have to be critiquing something like this. Again, is this realistic? Is this not realistic? Again, I'm sure this happens.
As you're attending, it is my decision. I am a certified provider for mifepristone. You are not.
Here he mentioned certified provider. Now, I had to look this up because I don't know any ER doctor that is certified in this. And earlier I mentioned how I contacted numerous ER doctor friends of mine from across the country. Struck out over 30. None of them are certified in this. So again, let's turn to the American College of Obstetricians and Gynecologists for that answer. There is something called the mifepristone Risk Evaluation and Mitigation Strategy, or REMS. This program is basically a set of requirements that govern the use of this medication. A clinician has to obtain certification by submitting a prescriber agreement form to the drug distributor prior to prescribing and administering mifepristone.
Okay.
I like big butts, and I cannot lie.
Whoa, you scared me there.
Want a pony ride, big boy?
What?
Excuse me, Myrna. I need to discuss a confidential patient issue with my colleague here. We need a little privacy.
Catch you later, sweet cheeks.
Don't mind Myrna. She's harmless.
She's handcuffed.
That's why she's harmless.
The scrub machine. This gives me PTSD and reminds me of residency every single time. So the medical student is not having a good day. He's going through a ton of scrubs. Some days are like that. Even as an attending, a gunshot comes in, you're working with the trauma for a clamshell thoracotomy. There's a lot of blood. I know I've talked about this before. Despite the gown, the gloves, the shoe covers, sometimes you still get blood on your scrubs and you need to change.
Christy needs to go through this a third time with a third doctor?
Yeah, that's our bad. Our computerized medical records have been glitching lately, and Dr. Collins' image didn't upload properly. Okay, crown to rump. That's top of the head to the bottom of the butt. It's how you measure gestational age, and we are at 10 weeks and 6 days.
I made it by 1 day.
I will order the medication. Dr. Collins will go over instructions on taking the pills when they come back from the pharmacy.
Thank you so much, Dr.
Oh,
Logan.
I'm glad I could help. Even more glad to see you have such a supportive mom.
Again, I think this is just opening yourself up to potential consequences, and this should be avoided. To say that this is not realistic is probably an understatement, as I'm sure this does happen. But again, just avoid putting yourself in this situation and get a formal ultrasound. So there's not going to be any question of what number you're going with. Again, I understand here, and I've had a few comments from the last episode as well, as they're saying, oh, the attendings are just trying to help her out. They're trying to help a 17-year-old out. I understand that, but realize we talked about this earlier. Let's go back to that quote from Mount Sinai. It states, medicines can be used to end an early pregnancy. In many cases, the first day of your last period must be less than 11 weeks pregnant. If you're over 11 weeks pregnant, you may need to have an in-clinic abortion. So again, you're not telling them that they can't. It's just in terms of the ER visit itself. So why would you kind of put that liability on yourself? Now you have one attending with an ultrasound, possibly a note, something uploaded, another attending with another note, something uploaded. You have a resident that's getting readings over 11 numerous times. You're having all of these ethical dilemmas going back and forth. Hey, I need you to put under 11 weeks. I need you to change your chart, get out of the chart. Why put yourself in that situation? Just give them an OB-GYN referral. Call up one of your colleagues at one of the clinics. There's no reason that this needs done right now in the ER. Again, you're opening yourself up to potential consequences and ramifications of this decision, especially when it comes to the medical record, that, again, there's no reason to take this risk. In this case, I think this is more for dramatic television appeal that this is being done. Otherwise, the simple answer to this is, we're going to refer you to OB-GYN. Here's a clinic. Here's the number. Your ultrasound's over 11 weeks, but we're going to refer you. They're going to go through everything with you, and they'll take care of you. But at this point, we're not going to be doing this in the ER. So overall, just a lot of issues with this case. Again, I'm not advocating for or against abortion. That's not the issue here, and that's not what we're doing with this critique, and I haven't been doing that at all throughout this critique. What we're simply reviewing here is not just the literature and the sources, but looking at various requirements, what all this means. We're reviewing the American College of Obstetricians and Gynecology, evidence-based literature and, the process of ultrasound, what that entails. Dr. Abbott likely had one reading before 11 weeks. She had at least two, potentially more. After 11 weeks, Dr. Robbie does one and gets under 11 weeks. Overall, again, this entire situation looks very bad without a formal ultrasound.
Appreciate you stepping up.
All good. I got you.
So here he states, I got you. Now, attendings will support our residents, but I think how the scene went about was just unprofessional and unethical in terms of what the attending is asking the resident to do. So let's recap this a little bit. So he asked her to delete her chart, delete the ultrasound. It would be as if she never saw the patient. Well, the patient's always going to know that you saw them. State there was an issue with the medical record, lying to your patient. State that the ultrasound did not upload. That's also a lie. Ignore the two readings that you got above 11 weeks. Overall, this is just a surprising scene. This scene plays out much longer throughout this episode. But again, for the sake of time, it's going to be the only portion I wanted to cover for this critique. Now, again, I've talked about this numerous times. I've said it numerous times. I probably should have been calculating how many times I've used the word formal ultrasound. And it's probably more than what I said for Princess CPR. But again, I think we've got our point here. But overall, again, this is for a dramatic television appeal that they're doing this. It's just not realistic and it's not practical. So we're just going to take another pause here from the critique itself and go through some comments I received. These are comments I received from the episode 4 critique. First one is from Helen Emily 9488. I'm a third-year med student applying OBGYN, and your videos on the PITT are by far my favorite on YouTube. As others are saying, you're a really great teacher, and I'm enjoying reviewing all the concepts, watching them alongside double-checking my thoughts as well with your commentary. Would love to hear more on your approaches to the differentials and any pearls on the more interdisciplinary issues. Please do not shorten these. I love it. I had a few comments saying the videos were too long, and then I'd have 100 comments of people saying, please make them even longer. This next one is from Andrew 65118. As an EMT about to get into schooling for my RN, I eagerly await for your reviews of these episodes like I wait for the new episodes to come out. It gets good and I can't wait for your next review, so thank you for that. I appreciate that. This one is from Ryan Q7230. I love every comment you make. From a 12-year RN, keep up the good work. Thank you for that. This next one, Cheese10151. I'm an EMT right now and I'm applying to ER tech jobs. I will also be applying to medical school this upcoming cycle. These videos are amazing and it made me think more and more about pursuing emergency medicine. Again, I thank you. I appreciate that. This next one is from Kenna Anderson, 7512. As someone hoping to go into emergency medicine, I love these. I look forward to them every week and I've learned so much from the level of in-depth analysis. Thank you so much. And I appreciate that. Again, anybody that's going into emergency medicine, I'm here to help you out. So again, feel free to send me an email. In addition to that, I do now have a membership that I started, at least for YouTube. So anybody that wants to be a part of that and have access to a few different things, that is now available as well. So again, you're talking personal statements. I'll go through it and I'll pick it apart for you. I'll help you with your emergency medicine application, what to expect on your emergency medicine resident interview or even your med school interview. I've sat on all those committees. I know what they look for, and I'm here to help you. All right, this next one, I believe that would be from Minutia, is how we say that, 7204. Keep it up, man. This is phenomenal content. I appreciate the long form. Hope you cover the whole season and beyond, and I definitely plan to do that. So again, the comments just go on, and it's terrific. I can't obviously cover all of these. There's this other one here from Real Roadrunner that says, yeah, about the CPR. I don't work in medicine, and most of my knowledge of medicine comes from TV shows like these. And my curiosity to research further on some stuff that I've seen here. I had my last first aid course 20 years ago, and I was in a situation where I had to do CPR. I probably would do it the same way they're showing on TV. Literally, because he watched it on TV, he was going to do it the same way. So I get that you're just making entertainment, and I accept that there's no guarantee for accuracy. Because of all this, I think it's very appropriate to mention that this way of doing CPR would have no effect. And again, I hit CPR hard on the previous episodes. Let's get back to the critique.
I had a tonsillectomy 10 days ago at St. Michael's. Started spitting blood about an hour ago. Good vitals.
Hey, Travis, I'm Dr. Robbie. How much blood?
A couple mouthfuls.
Can you open up for me?
So this is a post-tonsillectomy bleed or a post-tonsillectomy hemorrhage. I definitely see a lot of tonsillectomy bleeds in the ER, sometimes one a week, sometimes one every couple weeks, but it's pretty common. Tonsillectomy is one of the most commonly performed procedures by ear, nose, and throat surgeons, with over 500,000 performed annually in the United States. To quote, post-tonsillectomy hemorrhage is considered a surgical emergency. Hemorrhage after tonsillectomy can be classified as primary or secondary. If bleeding occurs within the first 24 hours after surgery, it's referred to as a primary hemorrhage. Secondary hemorrhage risk occurs after 24 hours. The risk of primary hemorrhage is 0.2 to 2.2%, and secondary hemorrhage is 0.1 to 4.8%. So our patient would be categorized as a secondary hemorrhage at that point.
Hey, Whitaker, Jesse. Got a post-tonsillectomy hemorrhage. Nebulized TXA, quick as you can. Let's go, trauma 2. So this can go south pretty quickly. You up for it?
Well, I can.
Of course you are.
So let's talk about treatment for this in the ER. Now, he mentions nebulized TXA. Love it. That's perfect. That's what we do. But when we do this, we're also assessing, the very first thing is it an active bleed at this moment or not? Given he's not currently coughing up blood, he's not currently, spewing out the mouth, as what can happen sometimes, it's temporarily stopped or at least really slowed down. So this is our chance at this point to prevent that reoccurrence, which could be even worse. So we're monitoring airway. We're putting in an IV. Sometimes we're putting on oxygen as well. We're putting them on the monitor depending on the situation. You're making sure that your patient is nothing by mouth, right? You don't want them eating through this. And you want to make sure they're in an upright position. So for the bleed itself, nebulized TXA can be used, but we do have a few options as well. Nebulized racemic epinephrine is another one. You can also do direct pressure with a tonsillar pack or gauze infused with TXA or lidocaine with epinephrine. Some patients may even get all of them. It kind of depends on the situation. So to quote one of the articles published in PubMed, Clinical Practice Cases of Emergency Medicine, they state, TXA is an anti-fibrinolytic that competitively inhibits plasminogen activation, thus promoting hemostasis and decreasing bleeding by forming a reversible complex that displaces plasminogen from fibrin, resulting in the inhibition of fibrinolysis. It also works by inhibiting the proteolytic activity of plasmin. So in reality, since we have a little bit of time here, giving nebulized TXA and consulting ENT is perfectly appropriate. That's what they're doing. In addition to that, we're observing. We want to make sure there's no rebleed. The big thing with that is we're consulting ENT because there's always the potential for surgical management of these cases.
Ready? Here we go. 1, 2, 3. Take long, slow, deep breaths on that. The TXA is going to help your blood clot.
Not the backwards stethoscope. We literally just talked about this, and I think it's happened a few times. I try to point them out every now and then, but we continue to see this in medical dramas. I understand that all of the actors and actresses underwent a medical boot camp for this TV series, and they went through procedures and different things. Basically, how to function as a resident for this TV series, how to function as a doctor. But time in and time again, we see this backwards stethoscope. Dr. Robbie, I was so hopeful. So again, this stethoscope here, you'll notice one side is angled one way. And again, this is to complement basically the ear canal and complement the anatomy. So when we put this on, it's angled towards the camera, it's forward. What we typically see is it's put on backwards this way. You can't hear anything with this. And so again, we're going to point this out every single time, but please just wear the stethoscope correctly. We're not trying to get you to identify a murmur. We just want realistic television. So if you see a doctor put on a stethoscope wrong, he's either new, he's not a doctor, or he just doesn't know what he's doing.
Hey, any medical problems?
No, just a ton of strep. That's why I had the surgery.
You take aspirin? Any other medications?
Lungs are clear bilaterally, no stridor.
Okay, sure. You feel like throwing up? Any pain in your belly?
No.
Now, these are all great questions that are being asked. We need to know if the patient's on any blood thinners. So if you have a patient on Coumadin, for example, or warfarin, so the INR is 6, it turns out they lied about their blood thinner to their ear, nose, and throat doctor, and now they're coming in post-tonsillar hemorrhage with what we call a super therapeutic INR. Now you have other things to worry about. Now, this is a younger patient. We never want to assume. I've had pediatric patients on anticoagulation, right? You can have clotting disorders. I've had pediatric patients, 16, 17 that have actually had a stroke because they have something called a patent foramen ovale. They had a DVT, they had a clotting disorder, and they end up with a stroke. I've had pediatric patients on blood thinners. So again, it's very important to know, even if they are a pediatric patient, in this case, less than 18, we still need to know if they're on blood thinners, adults for that matter as well. But again, this is a younger patient. We don't want to assume, you have to ask. So it's important that we know the medical history, any blood thinners, the last time they ate. We're listening to lungs. Are the lungs clear? Listening to lungs with a backward stethoscope, right? That tells us they did not aspirate any blood yet, which is good. Now, any nausea or vomiting, abdominal pain, these are great questions because this would likely signify active bleeding and the blood causing upset stomach and abdominal pain. So overall, perfect questions. Love it.
Labs?
CBC, BMP, maybe coags.
Add a type and screen just in case.
Yeah.
So getting labs is perfect. Is the patient thrombocytopenic? So their platelets are low and that's increasing the risk for bleeding. Are they anemic? Have they bled so much that they actually need blood? Here they state type and screen, which is awesome. This is just in case they have to give blood later, so I love this.
Good sat for 98%. BP's 115/80.
Okay, good. 4x4 and a ring forceps. Let's take a look.
Head back, open wide for me.
What do you see?
No active bleeding, but there's some white and dark brown stuff where the tonsils used to be.
That's good. That's a fibronesh clot. That means the TXA is working. Your parents on the way?
They're in Baltimore for a wedding. I didn't want to bother them.
Trust me, they're your parents, and you are in an emergency room, and he's never a bother. Write their numbers down, and I will call them. Call head and neck. Stay with him until they get here, okay? Good. Pen?
Get it.
Just have a seat and we'll be with you shortly.
Well, I've heard that load of bullshit before. Took me all the way back there just to stick a goddamn thermometer in my mouth,
Repeat vitals every 4 hours.
No. He had the surgery at St. Michael's, but he's here now. No, he doesn't have a car. His parents are out of town. Okay, well, how am I supposed to send him back to St. Michael's? We'll call him an Uber? You can't, that doesn't make, hey, hello? Hello?
What's wrong?
So here we did find out that he did consult ENT, which is totally appropriate. But we also find out a little bit later that ENT in the hospital actually refused to come in and see that patient because they did not do that surgery. So this is realistic, as this definitely can happen, but it's wrong in that it should not happen. So I think the part with this case is, let's actually turn to EMTALA for this one. This is the Emergency Medical Treatment and Active Labor Act. And of course, there's actually one other source I want to use for this, and it's actually the president of Bitterman Health Law Consulting Group. Why not talk about a law consulting group's take on this in addition to just EMTALA itself? So if the consultant refuses to come in this case ENT, there are Emergency Medical Treatment and Labor Act implications because of this. Now, if the consultant refuses to come to the ER to see the patient, there is no doctor-patient relationship established, okay? Therefore, the on-call physician has no medical malpractice liability. However, all right, this is the key here. However, if the on-call physician refuses to come in, he or she may be liable under EMTALA, for which he or she could be terminated from Medicare or fined up to $120,000 for failure to appear when requested. There are also implications for the hospital as well. If the consultants do not come in after an emergency physician requests it, once the emergency physician determines that the patient has an emergency medical condition, the on-call physician is legally obligated under EMTALA to come in. If and only if the emergency physician cannot stabilize the patient, it needs the on-call physician service to stabilize. So this next part is where it kind of gets a little bit sticky because we don't actually know the conversation, or at least the beginning parts of the conversation that the med student had with the ENT. Now, I can't critique it in terms of, hey, a resident should have been making that phone call or an attending should have been making that phone call, because as a med student, I did this numerous times talking with ENT, but it really has to do with how that case is portrayed to that ear, nose, and throat doctor. So at this time, you can argue that patient's stable, right? There's no active bleeding. The patient's getting nebulized TXA, so you're almost at that in-between point. Now, even if the ear, nose, and throat doctor is in the OR, right? They can't come down right now. They're in the OR. If they were to state, hey, I'll be down after my case is over, but based on how this conversation went, it sounds like the ENT actually wasn't going to come down. But at the end of the day, in this case, a post-tonsillectomy hemorrhage is considered a surgical emergency. An ENT should have at least come down to see this patient, or at least told the med student, hey, I'll be down once I'm done with the case, or hey, I'll see the patient here in a little bit, I'm busy. They should have at least come down and kind of conveyed that.
They said it is not their job to fix another hospital's problem. Don't worry about it, though. I'll talk to my attending. Oh, shit! I need a little help here!
And there goes another pair of scrubs, and the significant bleeding starts of a post-tonsillectomy hemorrhage. At this point, a few things need done. Airway, resuscitation, and potential blood transfusion become most important at this time.
Okay, come on, open up. That's a post-tonsillectomy hemorrhage.
Yank out and sponge stick.
He was stable, then it just opened.
Hold the blood bank, 2 units, hold blood, get a second line.
Head and neck would come down to see him.
Assholes.
He's tacky to 120, his sats are down to 90%.
Okay, get a high flow nasal cannula, 100 of ketamine, set up the glide scope. Hold suction. I'm gonna try for direct pressure. If head and neck still won't come down, call Garcia.
You're good.
So I love this. He has suction. He's requesting an additional peripheral IV be placed, requesting blood as well. He knows that even if this patient is not anemic, given the significant hemorrhage, that we're likely going to need blood product. Now, what I do is I look in the mouth. I'm going to suction to locate which side the bleed is coming from, and I'm going to apply direct pressure. Oftentimes, it could be in a couple areas on one side of the tonsillar crypt versus the other. So we kind of talked about this before. Again, we have the 4x4s, we have the ring forceps. And what you'll notice, again, with these 4x4s, they're very porous. You put this in the back of on the back of the throat. Once this is soaked with blood, this is just going to drip off. You need something that's more direct. Now, how can you spread this out? How can you do something a little bit different? What can we do here? Fox swab. All right, this is what I like to use. And so this Fox swab itself we use for a multitude of things. But this is a little bit smaller one. We have ones that are bigger than this as well. But typically, I'll soak this in TXA, and I'll actually put this in the back of the tonsillar crypt. So when we do this, we're putting it directly over the bleed. We're literally tamponading the bleed. When this is soaked with this pressure, this is not going to drip through. This will just stop the bleeding. And so I've had plenty of patients before where we put this back in the tonsillar crypt, it's soaked in TXA, sometimes it's wrapped in 4x4s and soaked in TXA, and it's direct pressure, and it stops the bleed. And I'll tell patients, go ahead and bite down on this part, all right? And sometimes this is enough to buy them time until they get into the OR. This is not a definitive treatment. They need the OR, but this is direct pressure. It allows things to kind of slow down. It allows them to get to the OR, and this would be the next best step. This is what works for me. I love it.
Ketamine on board to intubate.
That's holding at 97.
Can you get an airway? Come on. Let's lie him down. Keep pressure on the scab. Nothing but blood. Can't see the cords.
So here he's using a glide scope with this bleeding, and this is a perfectly appropriate choice for this. Again, in these difficult intubations like this, we want a camera, we want to be able to kind of see everything. So using a glide scope, the camera, the ET, like that's perfect. So that part of this, that decision is accurate. The issue is you'll notice here, and really all my respiratory therapy friends that are watching this are again probably cringing at this because there's no rigid stylet here. Now, when we do a direct intubation, for example, and I've talked about this, I think it was in episode 3. When we do a direct intubation, either with a Mac or a Miller, we're looking directly with the eyes into the airway itself. All right, we have our ET tube. The ET tube, it's very flimsy. I don't actually have one on me, but it just bends. It's very flimsy. All right. With a direct intubation, we put a soft stylet in there. Now, that soft stylet can be bent a little bit to the curvature of the ET tube, but it's designed to just slide in. Now, with a glide scope, you'll notice they have this on the camera itself. It's almost like this kind of Mac-shaped end, if you will. And when you put that in there and you have an ET tube, all right, you need to be able to match the angle of the glide scope itself. And you're not going to be able to do that with an empty ET tube. At that time, you need a rigid stylet in there. I think this is the second time in this series so far, maybe even the third, that we've actually seen an ET tube without a rigid stylet. In reality, for this filming, just take a regular rigid stylet, cut it in half, cut the ET tube in half, right, and then just show half of it. That would be realistic.
SAS 94.
Not sure we have room for the tube with the sponge stick.
If I pull out, there's gonna be even more blood.
Doesn't look like you secured that airway.
We're working on it.
All right, so here he's got the ring forceps, he's got the 4x4, right? He's got that sponge stick in an attempt to slow the bleed. But again, as we've talked about, we need something more direct. I doubt that sponge stick is helping slow anything at all. At this point, you know, it's filled with blood, it's just seeping around it. Again, once that 4x4 is soaked with blood, blood is gonna leak out. This has stopped nothing. I would definitely recommend the Fox swab here.
Bougie,
Open a Craig tray and prep the neck.
hold on. I'm going in blind with the bougie. I might be able to feel the tracheal rings.
And I might have a 3-way with Madonna. Move.
Not happening. Pressure.
Make room for the grown-ups.
So here they're using the bougie, and I absolutely love this. A bougie is basically a thin, flexible tube, semi-rigid, and we often use this during difficult airways or even for an ET tube exchange. Patient is in the ICU, for example, and they have a smaller ET tube, and you need to change it out for a larger ET tube. You actually take this bougie, slide it through the ET tube, back out the old ET tube, and slide the new one over it. So at the end, there's actually a small curve or hockey stick type angle. This coude tip is typically at a 35 to 40 degree angle. So when the mouth is full of blood, for example, you're inserting this slowly. Now, it's not rigid enough to cause damage. You know, it's semi-rigid, but you're inserting it slow. The hockey angle is faced up. And what you're doing is you're feeling for that bump from the bougie rubbing against the tracheal rings, right? The trachea has rings. And if we're in that right spot, we're going to feel kind of that bump. And we know that we're in the right spot. Now, obviously, if it's slid into the esophagus, you're not going to feel those bumps, and you're just going to back it out and you're going to try it again. And a few times, you know, really difficult airways, I've actually had to even bend the bougie a little bit more because I got to get it angled up. So at this point, when you're in that right spot, now you're going to slide the ET tube then over that bougie. And sometimes, again, you're still going to have the glide scope in there because you want to help give some support. You want to help that ET tube basically be able to slide in over that bougie. So again, the bougie is small enough to allow for this, and we use this during difficult airways, and especially in this case where you can't actually, you know, see anything because of how much blood there is.
Okay, hold on. We can try a retrograde intubation.
A what?
There's no obstruction. We just can't see what we're doing. So we take a needle and we put it in the cricothyroid. We run the guide wire up and out the mouth, and we slide the ET tube up over the wire.
Never seen one before. That's 90.
No time to play MacGyver with this kid. Time to Craig.
That'd be quick.
You got one shot, and then I cut.
So in TV medical dramas, again, we want to do the most exciting procedures, right? That's what's going to get our audience really interested. That's really, you know, into the program itself. And so I kind of figured the retrograde intubation was going to be coming sometime. You really can't have a ER TV medical drama without doing a retrograde intubation or a retrograde guide wire intubation. So I wanted to briefly explain this before the procedure itself so that you can kind of go with what I said and then watch the procedure and then see how accurate this is. This is one of the many ways to help secure a difficult airway. Now, We have a surgery resident standing by that's super anxious to do a crike, and I don't blame them, which we've already covered on a previous review, and it's a lot of fun, so we don't want to cover that again. I figured the easiest way to explain this is to show one of the kits that can be used, and that's the Cook Catheter Retrograde Intubation Kit. So you're going to be puncturing the cricothyroid membrane with a cannula. Aspiration of air confirms the correct location of the needle. Then push the cannula off the needle, sliding it in. The next part is honestly probably the hardest part, and that is you're feeding that flexible end of the guide wire down the cannula into the trachea itself and up towards the mouth. I will say on the few of these that I have did, that is the hardest part of this. So you'll notice on this next scene, what he's doing is when he's putting that cannula in, right, it's kind of angled one way. You're angling up towards the head because realize the guide wire is ultimately going to feed through there, and you don't want to put it in and that feeds down to the lungs, right? We're trying to get it to feed up. And so that's honestly probably the hardest part with this. And what you're going to do is hopefully if you get it up there, you're trying to observe the tip of the wire coming out the mouth. So essentially you have the wire through that cricothyroid membrane, and then it's out the mouth as well, right? We're not going to move it like this, but essentially you're watching for it to come out, and then you still have that part that's there. And so let's take a look here, and I'm going to pause throughout this. So great view here of the cricothyroid membrane being punctured. He's aspirating air, so he knows that it's in. Next, he's going to be inserting the guide wire through the needle.
Okay, I'm in. Guide wire. Let me know when you start to feel it up top. Nothing yet. More suction. I'm trying.
So he's looking from above. He's looking into the mouth for any chance at all that he's going to be able to see that guide wire kind of coming up so he can grab it with forceps and then kind of secure that, and then we'll be able to do the next step.
Feeling in there. It's got to be there somewhere.
It's curling up.
So that's down to 89.
Guys, this is not working.
Just give me a second.
Until you rest?
Oh my God, I'm gonna lose another patient.
Stop, Baker. He's got this.
So that's down to 87.
Okay, I'm gonna redirect the wire.
So that's still dropping. 86.
You got this.
So he mentions he's going to redirect the guide wire. Again, that is perfect. That is spot on. Again, that is such a small detail that is included here, because what other TV medical drama, right, is going to mention redirecting a guide wire on a retrograde intubation of a difficult airway, of a post-tonsillectomy hemorrhage? That's such a small detail. So again, I applaud the writers for that particular one. Again, it's the small details that make this so realistic.
Andy, and if you'd like, you can watch on the screen. Okay. Excellent view of the cords, Dr. Mohan.
So I only paused here for the glide scope again. Now, with this particular case, we have not covered this one because of the amount of time that it would take. This is actually a patient with sickle cell that had an acute chest syndrome that's actually being intubated for worsening respiratory distress and respiratory failure. And the reason I didn't cover this one is just the amount of time that it would take. If you add up kind of all the time and all the videos I've did so far, it's over an hour on a few of them. And so I believe that this case of sickle cell needs its own video. It's that important. And this is actually one of my publications. I actually have a few publications on this. And so I think in a future video, we'll talk about sickle cell, we'll talk about acute chest syndrome, and we'll talk about aplastic. We're going to talk about simple transfusion. We're going to talk about exchange transfusion, all the things that accompany that. Overall, I think the biggest part with this case is that this ET tube did not have a rigid stylet. And for that reason, it makes it not realistic. Again, without a rigid stylet, your ET tube will not be able to make that turn around that curvy linear shape of the glide scope itself. Also, I first thought this was respiratory here. Nope, this is a nurse. So where is respiratory therapy? Again, I've talked about it. We rarely see them in the ER. And so typically we're guessing at where they could be every now and then. Now, I pointed it out in episode 3 where I believe I saw a couple of them. Only parts of this scene are realistic, and that is a senior resident is supervising intubation. That's realistic, right? Doesn't have to be an attending in the room. So we do have a senior resident in this case supervising intubation, totally fine. It's appropriate. And the fact that the patient is being intubated, given the clinical presentation we learn about, worsening respiratory failure, hypoxia, that is pretty realistic. But outside of not having respiratory present and not having a rigid stylet, this whole scene is just overall not realistic. Seriously, where is respiratory here? When we intubate anybody in the ER, especially in a trauma center like this, you're not going to have a resident, is senior resident and only a nurse. You're going to have respiratory therapy. I don't understand why these scenes keep happening like this. Intubation without a rigid stylet and a gyroscope, respiratory is not present. It's just not realistic. Now, it's not uncommon to have a senior resident supervising. When I was a chief, I did this quite a few times with a junior resident. So again, that part is realistic. The rest of the scene, not so much.
I'm in. Inflate the balloon. Good breath sounds bilaterally.
That's 92 and raising.
That's it? You're done? Yes. It all went perfectly.
So I guess at this point, let's just give the benefit of the doubt to the producers and the writers that all the RTs in the entire hospital, the reason we don't see them in the ER is because they're all busy, right? The entire hospital, every single RT, none of them are in the ER. They're all on the floors. They're all in the ICU. Not one of them in the ER. So overall, producers, just show us RT, right? Show us a respiratory therapist. Please give them some screen time. They play such an integral and vital role in our emergency department. Every single respiratory case, every single trauma case that comes through. So give them some screen time. Again, respiratory therapy, I love you, and I'm going to call this out every single time.
That's 84. We need to bag him. Still not seeing it. Stop spinning like crazy.
Okay, we're done playing doctor. Lose the wire. I'm cracking this kid.
All right, we tried. I'm sorry.
No, wait. I've got it.
You still don't have an airway.
Keep the laryngoscope in place and the tube passes easily. Pass the T tube over the wire. Come on. Hang on to that wire. Do not let go of that wire. Okay, I'm gonna give you a little slack so you can get past the cords. Yeah. I feel like at the trachea.
25 centimeters at the lips.
That ought to do it. Pull the wire. Bag him. Balloon's up.
So now with this next scene, the wire is finally in the mouth. He sees it. He's able to grab it with forceps. The next part is sliding that ET tube over the wire itself. Now, you want to keep the glide scope in to help with visualization here, but also it allows some of the room to put the ET where it needs to go. When you confirm that you're through the cords, you can then pull the wire out from above and you're good to go. Overall, this was an awesome scene and more realistic than missing the stylet intubation on the previous scene.
Yellow on CO2. That's good.
That is very good. Good breath sounds bilaterally.
Stats coming up. 90, 92.
Guess you're gonna have to save that scalpel for another day.
You guys got lucky.
No, we got skills, baby. We got skills. Keep gauze on the car.
Yeah, copy.
Ordering propofol and fentanyl drips.
Oh, nice of you to join us, Dr. Flores.
Sorry, got stuck in a nasty radical neck dissection. Still bleeding? Not with direct pressure.
We got the airway, you get the bleeder.
Or standing by.
So I can cancel the Uber?
Let's get him upstairs.
Fresh sponge stick for you, Whitaker.
You need me to stay with the...
Your patient did a good job. It's only till the anesthesiologist takes over. You got it?
So ENT shows up. So I love this. So maybe the attending called and we didn't know about it. Maybe surgery notified them and we didn't know about it. Or maybe ENT even realized it could potentially be an EMTALA issue for him in the hospital and he just changed his mind. Or he heard that this patient was going to be intubated and he's probably thinking to himself, oh shoot, I should have came in. So at this point, as a medical student, I'm sure we're thinking, I told you so. And I've had that numerous times as a med student. I'm thinking back in my head, I told you so. Now, in terms of the comment he made, myself, I probably would have said the exact same thing if we're being completely honest here. Probably shouldn't say it, but knowing myself, I probably would have said it. And so overall, I did like this part.
Yeah, I got it.
Get yourself a fresh pair of scrubs on your way back down.
So he definitely needs another pair of scrubs. I actually lost track at this point how many different pairs of scrubs he has went through.
Driver lost control as the police cars were closing in.
Check it out.
It's difficult to tell from this angle, but it does look like they may have hit something.
Damn! That's in our zone.
Ambulance crashed in our catchment. Get ready for incoming.
How many you think?
Other than the driver, no idea.
We see here the stolen EMS rig is now on a police chase and is now all over the news. Now, there's a few things that take place throughout this episode, and they're kind of making different bets and things like that. And overall, I don't think that part's realistic, and I just chose not to put this in here. But we find out that the ambulance had crashed, and episode 5 comes to an end as we find out that we're going to be getting whoever is in that ambulance. So another awesome episode. So that concludes the episode 5 critique. I will say overall, while not 100% accurate, I firmly believe it's the most realistic medical drama on television. And if a TV ER medical drama can make an ER doctor like myself feel like I'm at work seeing patients and it's my day off, if it can do that, you know that it's a good ER medical drama. So far, I've completed 5 episodes. We're gonna do all 15. And right now, I'm still saying this is the most realistic. Again, while not 100% accurate, one of the most realistic medical dramas, if not the most realistic medical drama on television history. So I do plan to review some of the other TV series, and we're gonna get to that eventually. But right now, let's move on to episode 6.